Hello, and welcome to Cutting Edge Health. Today, we're talking about buprenorphine, and we're going to give you insight about exactly what it means, how it can be of a benefit, and we'll be back in just 1 second. Okay, welcome back, and thanks for joining us today. Today, we're talking about buprenorphine and how it's a unique and interesting medication that can provide pain relief that most people don't know about. So normally, when people think about buprenorphine, they think about one medication in particular, and that is a medicine called Suboxone. And so Suboxone is a medication that's used predominantly for helping people to be able to get off of pain meds. However, this is not what we're talking about today. We're not talking about a medication like Suboxone. Instead, what we're talking about is a different type of medicine. What we're talking about is the following: Butrans. And we talk about Butrans, it's a type of medication similar to Belbuca that's reliant upon buprenorphine, which is a partial agonist. And we're going to explain to you what that means and how that makes an impact. And in essence, it's a medication that doesn't have respiratory depression like other treatment options do, like other traditional pain medicines like a Vicodin or morphine or something along those lines. It has less likely for dependence and addiction, and it has milder withdrawal symptoms. So when you take a look at its degree of potency, it's about 25 to 50 times higher than the equivalent dose of morphine, and has been noted to be safe for elderly populations and those that have renal impairment. In addition, it does not affect sex hormones or the immune system, much like traditional morphine and other opioids do. So there's a lot of potential value behind a treatment such as this, right? So what are some of the myths about buprenorphine, and does it make sense? So some of the myths are: it doesn't control pain, which is untrue; that it's illegal to prescribe buprenorphine for pain without a special license, that's also untrue; that it's less potent than morphine, that is untrue; that it cannot be combined with other pain medicines that are what attack a full mu agonist. So in essence, these are medicines that normally work on a traditional mu receptor for pain relief, but it can be combined with other medicines, and that's a fallacy. In addition, is that it cannot cause any form of respiratory depression. It can, and we're going to talk about and show you what the respiratory depression can cause, but it's much less compared to other medications. And that the buprenorphine naloxone combination has minimal risk of abuse. It has been shown to have abuse, but it's less than what it is in compared to other medications. And naloxone in combination with buprenorphine blocks pain control, which isn't quite accurate. So as we always talk about when we have these live streams, one of the things that we do is really try to lean into the science so people can understand exactly what it is that we're talking about. So when we talk about science, one of the papers that we reference is the following: Opioids and Substance Use, Understanding Buprenorphine for Use in Chronic Pain. And this is a compilation of a number of different experts, one of which is very well known, which is Lynn Webster within Pain Circles. And that article has a number of references throughout the aspects of this talk. So first of all, we're going to talk about the history of buprenorphine and how long has it been around. Because if I mention buprenorphine, Butrans, Belbuca, even Suboxone, most people would say, oh, I only heard about this in the last 10 or 15 years. And if I was to take a sample and poll, you know what? Let's do that. For those of you who are watching, can you maybe take a guess as when you think buprenorphine was actually first manufactured and utilized? Send it to me in the comments. Let's see what you guys get. Any guesses? Okay, well, I'm guessing you guys are pretty quiet. You don't want to take a shot at it. Okay, fine. Then I'll give you the answer. So, buprenorphine was first manufactured in 1966, so quite some time ago. Is when it was discovered. It was launched in the UK as an intravenous opioid analgesic in 1978, so also for quite some time. And then, in addition to that, the FDA approved it in 1981. So there's one question that came out or aspect was 20 years. And yeah, it's been longer than 20 years. It's been out since before 2000. Almost 40 years is when it actually was approved by the FDA, right? So you can see right here, it approves injectable buprenorphine as classified as a Schedule II back in the 1980s. So for those of you who I might not be dating, but dating themselves as the following this is back in like MTV years, like Cyndi Lauper and I don't know, other individuals around that time frame. So this is way back in the day. This is not like 2000s. This is definitely precedes that. So we take a look at how it's kind of developed. The use of the Subutex was developed in 2002, so nearly 20 years ago for that. And then the FDA approved different treatments like Butrans in 2010, so almost 12 years or so ago, and Belbuca has been out for 7 years, almost 10 years. So these medications that many, not only patients, but also providers haven't heard of, they're like, I don't know anything about this medicine, has been out for nearly 40 plus years, almost 50, since its original inception. And there have been various different products that have been developed from there. So let's talk about what makes it unique. So we're going to talk about the receptor. Now, don't get bored and glazed over in terms of your eyes. Stay with me. It is kind of important because it explains how this makes this medication, this drug, different than others, right? So that's what we're going to talk about. The cartoon is going to kind of give a little pictorial representation of the receptor, but then we're going to get an explanation on both the next slide and the slide thereafter about what makes it unique. So we take a look at the buprenorphine itself. It has an affinity for those receptors that produce analgesia, right? And so receptors themselves are things like the mu receptor or the kappa receptor that's in place. But the interesting thing about buprenorphine is it has a high potency and a slow dissociation rate, meaning it binds, but it can last for quite a bit of time, and it produces pain relief even at lower doses. It has a pretty high binding affinity, which means it can be present and move other medications off of that. And it's a partial agonist. And this is a key concept because a partial agonist, it actually signals for the regular agonist to have fewer opioid-related adverse events. So I'm going to say that again, have fewer opioid-related adverse events. So for my patients, they know that we're doing things differently with the utilization of buprenorphine more aggressively. And one of the reasons why is because we're looking to have less side effects. Now, the question is, does it have no side effects? No, that'd be a bold-faced lie. And I think any claim by any drug that would say that they have no side effects wouldn't be true, right? I was just talking to a patient today that was grumbling to me and was saying to me that I know this medication has side effects. And I'm like, yeah, you're right. It does have side effects. The question is, will they be as strong or as likely as other medications that may be able to give you the same degree of benefit that this medication can? So as we talk, what I would say is the other thing that's of interest is that it has a low intrinsic activity, which can be able to have it be active even with an effective analgesic, which is a little bit different than some other receptors. So let's put this in context. We take a look at this slide, which is a little difficult to see, but the green blob is like a traditional pain medicine, like a Vicodin. And the little yellow dots in the upper corner are buprenorphine. So normally when you have something like a Vicodin comes in and it binds that receptor, a hydrocodone, it gets there and it has this activation that takes place. Well, buprenorphine actually is a medication that can be able to move these big globs kind of out the way, bind the receptor, give analgesia, but doesn't give the same type of side effects that you otherwise might see. So people are like, okay, well, that's nice, doc, but why would I want to make that transition? Why would I want to potentially move to a medicine that I'm not familiar with? And this is probably one of the most difficult questions because people like to do what they know. And I understand that. But one of the reasons why we're interested in doing something that's different is for a few reasons. And the first is this. Let's see when it's going to cooperate. And that is this. So this graph makes a whole host of difference. And one of the things that you can see is a picture that looks at opioid dependence, not quite addiction, but dependence. And so you can see the purple graph, the pinkish graph, and then that yellow line, which is separated by something that's called an agonist and partial agonist, which is what buprenorphine is. It's partial agonist. So the degree of addictive potential for things like fentanyl, hydromorphone, morphine, they are similar and approximate things like heroin. While using something like buprenorphine has less likelihood of having addiction, right? And I have a number of patients that say to me, well, you know what? I've been using this medicine, just tramadol, for years, and I haven't had an addictive component that has really bothered me. And my counter to that is the following, are we sure your pain's never going to get worse? And if your pain does get worse, then what do? Do we add more medicine? Do we do something different with the dose? And then at that point in time, when we've had to deal with that, how likely is your level of addiction at that time? Now, I'm not saying that there are not use cases for a whole host of different pain medicines and that this is the only medicine that has value. Will it work for everyone? Of course it will. But if we have the ability to be able to say it's less likely for addiction and it's also less likely for some other side effects that we're going to talk about a little bit later, why would we not at least consider it and put it within our armamentarium? Meaning, it's not going to be the only tool that we use to solve a problem, but it's one of the tools that we can use to solve a problem. And it has history, despite what many people think is that, oh, it's only been out for 5 years. I'm not sure if I trust it. It's been out for 40 years. It's older than some of your children, right? So now you're telling me that you're not going to trust this medication because you don't necessarily have personal experience. Well, maybe there might be reason for you to have some understanding about it as we go forward. So who might be a candidate for this? So if you have a medication like a fentanyl and you're using 25 mics or less, oxycodone of 60 milligrams per day, hydrocodone 90 milligrams per day, hydromorphone or Dilaudid of 16 milligrams per day, oxymorphone of 4 milligrams per day, or tapentadol, also known as Nucynta, pretty much any dose you can be able to convert over. So those are some pretty hefty doses, meaning so it has a degree of potency and of efficacy that actually can be able to help for a lot of people. So let's take a look at a couple of different papers and some myths, and we kind of do some myth busting here and there. And then we're going to get to some explanations about what are some of the other values to it. So some of the myth busting is sublingual buprenorphine or naloxone equivalent to sublingual buprenorphine alone? So buprenorphine bioavailability is slightly greater than the mixture when you compare it. And technically the differences are small, but they're not clinically significant. So really, we want to make sure that we consider kind of what it is from a milligram to milligram dose. And the addition of naloxone does not influence buprenorphine's availability in the body. Okay. So let's ask and answer a few more questions. Can buprenorphine be combined with other potent opioids? And this is one I get from the pharmacy all the time. Because buprenorphine has a high affinity and long dwell time on mu receptors, it would seem rational that it would produce additive analgesia when combined with other opioids and vice versa, such that potent opioids can be combined with around-the-clock buprenorphine. And so, in essence, I've had pharmacists say, oh, not talking about a buprenorphine and naloxone mix, just buprenorphine. They've worked under the assumption at times that this medicine can't be used with other pain medicines at all. And that's not really accurate. It could be if it needs to be. The question is, do we need to do that? Okay. What are some of the other myths? Rotating to buprenorphine from another opioid is going to cause a risk of withdrawal. So buprenorphine causes withdrawal in a stop-start strategy when used in opioid rotation, for high doses of potent opioids. And there are several factors that can predict what the occurrence is. The first is if it's the dose of buprenorphine, the time interval between stopping the pain medicine that was previously used and starting buprenorphine, the accumulated physical dependence, and the dose of the previous opioid prior to doing the switch. Withdrawal is unlikely if individuals are receiving less than 60 milligrams of morphine a day, or if you're using something like methadone, 30 milligrams per day, both of which are pretty hefty doses, relatively speaking. So the question about withdrawal in this context is probably not that likely. Okay, so QTC intervals. So let me just kind of explain this real quick for those of you who are watching who may not know. When we talk about QTC, what we're looking at is an interval that's present on the EKG that predicts potential arrhythmias that can result, right? So when we look at QTC, one of the most well-known medications that can be able to alter QTC is a medication called methadone, and it can predispose towards arrhythmias that you need to measure it. So there's been questions about, will buprenorphine do the same thing? And so it can change repolarization and it can prolong QTC to an extent. However, the thing that's interesting is 100-fold less. 100-fold less has that degree of affinity than methadone. So for most patients, because the QTC is minimal change, it really doesn't have that same dynamic. So as you can see in those bottom three lines, despite this finding, this has not been a concern in the maintenance literature, and there's not been a need to monitor buprenorphine with serial EKGs or maintenance therapy as it has been with methadone. So the cause of likelihood or concern for QTC and arrhythmias is pretty much small. Okay, so let's talk about some conclusions that we've seen from some of the papers, right? So one is that in treatment of severe pain in cancer patients, buprenorphine, oxycodone, fentanyl, and morphine show similar analgesic efficacy. So saying it again, for some of the most devastating pain, you can be able to use buprenorphine, oxycodone, fentanyl, and morphine interchangeably, and have been able to see that there has been a smaller negative effect with the utilization of buprenorphine compared to some other things. Okay, another paper that takes a look. So it basically states that opioids have been associated with increased adverse effects in some populations, but opioids that are safer for use in kidney disease include oxycodone, hydromorphone, fentanyl, methadone, and buprenorphine. Now, methadone, I actually disagree with because it actually can have some issues, even though it's more liver-oriented, but buprenorphine can be used predominantly within the context of renal failure. So let's take another look at another case context of dependency and whether it makes potential sense in terms of abuse and other things. So this one paper looked at the abuse of medications and how frequently it occurred. So on the far left hand, I believe, is hydrocodone, then oxycodone, then codeine, and tramadol. And the green is using it without misuse, and then yellow is misuse. And you can see proportion-wise, hydrocodone has some of the highest use of misuse comparatively. Oxycodone, codeine, tramadol, morphine, and buprenorphine kind of falls right in the center, particularly when you combine it with the aspect of naloxone, which we'll talk about in a later context. But its utilization is really not quite that prevalent in terms of misuse compared to others. So is all buprenorphine created equal, or are there differences between them? Well, there certainly are differences. So let's talk a little bit. So when we talk about the elements of buprenorphine, we have a number of different variants that exist. As you can see on the left-hand side, there's 6 different types that can be present, and they're used for different things. But you can see the bioavailability of things like Belbuca at 55%, different than what Butrans is at 15%. And the dosage is different, and the amount absorbed is different. So the interesting piece about this, and the reason why this table is in place, is because people will think that, oh, one is 20 milligrams versus one is 1 milligram. And so I'm really thinking that I have an idea about how this is going to affect me. And quite frankly, the different variations between buprenorphine have to be kind of taken individually to be able to be assessed from a clinical standpoint. Okay, so one thing is it safe? 2 is, does it work? And 3 is it convenient? So when we talk about convenience, we talk about side effects that are associated with it. So what are some of the common side effects that are associated with buprenorphine? And they're the following. So you can see that there's some nauseousness and vomiting that can occur. And it typically happens with the initial dose, but most of the time that can be tempered by using a lesser dose to be able to start off with. It doesn't necessarily affect the analgesic efficacy. Can you have some constipation? You can, but quite frankly, you can have that with any opioid. Might you have some itching, some insomnia, and some shortness of breath? You could. And we're going to talk about shortness of breath in just a little bit, but we're going to give an idea about what that really means from a broader nature of how and why it might be a bit more safe. So we take a look. One of the things that we can see is that buprenorphine has various different indications. You have the standard straight buprenorphine, you have buprenorphine naloxone, and then you can have that element of kind of the long-acting formulations. So the portions for pain, Belbucan, Butrans, and Buprenex have different administration routes, whether it's the sublingual film versus the portions that are a transdermal patch versus intramuscular intravenous administration. And one of the things that can really be kind of put forth is this context of respiratory depression. And what has been shown with the utilization of these medicines is that respiratory depression there's a ceiling effect. So when you compare it to medications like morphine, hydromorphone, hydrocodone, oxycodone, those type of medicines, the degree of respiratory oppression is much lessened. And so the likelihood that you're going to cease and stop breathing with utilization of this medicine is much markedly reduced compared to a traditional pain medicine. So there's a whole host of different reasons for why using buprenorphine has value. There are some side effects that are associated with it, just like there are with other medicines that are out there. But at the end of the day, even though it's a weird name and it's not necessarily rolling off the tongues of a ton of different people, there's value for why this might be a medication that may be of use for those people who you care about, those people who you value. And some of the main things are that it can not only work and be efficacious, but it also can decrease the likelihood of dependence on the medicine, that it's not likely to be able to stop the breathing and respiratory function that's associated with it. And it really can be able to be utilized in combination with other medications or solely based off of how it works and the value that it can bring. For those of you who join us live, we always appreciate you joining us and giving us your support. And for those of you who are watching us later, hopefully it will be of value to you and for those people you care about. Again, Cutting Edge Health is intent on trying to be able to help you understand not only how to be able to beat your pain, but how to be able to improve your life and your functionality. Thank you so much for joining us and have a fantastic day.